So, good afternoon everyone and welcome to our monthly Heart and Lung Research Institute seminar. I am delighted this month to introduce two speakers, the first of which is Dr David Arnold, who is a respiratory physician who's joining us from the University of Bristol, and second is our own Scott Ritchie, who is part of the cardiovascular epidemiology unit and is going to speak to us about cardiovascular risk. Our first speaker is going to be David Arnold, who's going to talk to us about pleural infections. David.
So much for having me here. Really amazing, impressive environment that you all work in. Seems to be getting bigger all the time, it looks like. My name is David Arnold. I'm a fairly newly appointed consultant at Southgate Hospital in Bristol. And, I'm just going to talk about pleural infection. Now, just as a sort of disclaimer, it's something I've got a real passion for, so I sometimes rabbit on for a while, so I'll try and keep it brief. But if you can imagine, pleural infection for a lot of people is a bit like pneumonia plus almost. So usually patients will get a pneumonia, they'll then get a little bit better, and in hospital they'll start then to feel a little bit worse. They develop chest pain, the shortness of breath gets a bit worse, the temperature gets a little bit worse. And so you think, oh, what's going on? You do a chest x-ray and lo and behold, some fluid has built up in the space between the lung and the chest wall. That's a pleural effusion. And then if patients are unlucky enough, that fluid itself becomes infected, and that's pleural infection. And I'll go into that in a bit more detail, but that's essentially what happens in my life's passion of pleural infection. Now, it is a disease, I always start with this slide, so sorry Charlotte, you may well have seen this before, but it just goes to show that pleural infection is a disease of some real heritage. I said I wouldn't move around, but I always move around, so sorry about that. It was first described by the ancient Egyptians, presumably some sort of hieroglyphics on a wall. But they were describing probably empyema necessitans, where the infection was actually burrowing its way from the chest through the chest wall, and then sort of popped like a sort of cyst. And then Hippocrates, as he often does, really professionalized the whole diagnostic and treatment process. So he said that if you sort of sliced into a patient, and if the stuff that came out was pure and white, the patient tended to do okay. If it was bloody and fetid, a great word, then they tended to die. He said that if you shook the patient vigorously by the shoulders, you could work out the character of the fluid within, and that was succussion. And then finally, the most sort of brilliantly, was the sign of damp earth. So a bit like a sort of ancient PET scan, where they would just smear wet mud on a patient's hemithorax, and then the area that dried the quickest was felt to be the most metabolically active, and therefore, presumably after some cleaning, where the sort of lancet was stuck to drain the fluid. It's fair to say that nothing really moved on for the next few millennia, or if anything regressed. So by the time Jupiter, the famous physician, got his pleural infection, he said he'd rather die at the hands of God than with the help of a surgeon, which was really how we treated pleural infection at the time. War, as it often does, not only advanced technology but also advanced treatment in medicine, and especially for empyema. The Spanish flu was ravaging US Army camps on the aftermath of the First World War, and these poor chaps were getting absolutely sliced apart by the surgeons to treat this pleural infection that was developing after Spanish flu. The mortality rate would range from something like sort of 90% to 95%. So even the most enthusiastic surgeon was probably thinking, oh, maybe we're not doing quite the right thing here. And by augmenting their approach by using a more sort of a more conservative drainage strategy, they reduced it down to 5% after the Empyema Commission was set up. Now, Professor Light is probably the godfather of pleural medicine, and we're kind of coming into modern day here, where he initially sort of did some early diagnostics and showed that the more acidic the fluid, the more likely it was the patient was going to go on to need some sort of procedure. We've come a long way since then. But probably pleural infection is still a little bit behind a lot of the other respiratory and cardiovascular conditions we study. We have some idea of how the bug gets into the pleural space, so most likely it's through consolidated lung and translocates across the visceral pleura. But it can come from the other way, so you can imagine that lung cancer or post-operatively, some come from the visceral pleural defects. It can hematologically spread as well, and I think that's mostly overlooked. We see patients a lot who've got no evidence of pneumonia whatsoever and then just develop pleural infections, sometimes after having a dental procedure. And then you can imagine abdominal spread from an infected ascites, spread from the mediastinum, or penetrating injury. Now, once the bacteria is in the pleural space, we do have a better idea of what's going on. You get a huge inflammatory cascade developing. It's an incredibly inflammatory condition. CRPs are kind of off the scale, neutrophil recruitment off the scale in pleural infection. That increases pleural fluid accumulation, and you might get a simple parapneumonic effusion. In fact, around about 50% of patients that we see in hospital with pneumonia, if you put an ultrasound scan on, about 50% of them are likely to have some degree of pleural fluid there. And I always tell my patients, you know, imagine if you've got an infected leg, it's going to swell up. The same thing happens in the lung. However, as I said, some patients get unlucky and bacteria start to replicate within that fluid. And if that happens, the pH of the fluid is driven down as lactic acid is produced, the glucose is driven down, and fibrinolysis, which is happening in our pleural fluid all the time, starts to get dysregulated. And you go from having a simple pleural effusion, so just like water in the bottom of a glass, becomes almost honeycombed, complex, and very much more difficult to drain for antibiotics to penetrate and for us to treat. This is the incidence of pleural infection. So this is just NHS digital data that we looked at a few years ago. And you can see that the incidence is rising and rising and rising in the elderly. Yeah, I don't really know why that is. Is it because we're picking it up better with more CT scans? Is it people living longer? All possible. But the mortality rate is static around about 10%. So this is a serious condition if you're admitted to hospital with it. And the length of stay is around about 14 days. It's a lot of burden. We'll often have 2 or 3 patients on the ward with pleural infection at any one time. I don't think it is just pneumonia. You know, pneumonia has a much greater average age in hospital and doesn't have this male predominance. And I can't really explain that male predominance to you. We could be a little bit lazier and say that men are less likely to go to their doctor early, so maybe they're more likely to develop pleural infection, not get their antibiotics. Are their teeth a little bit worse? Do they drink a little bit more alcohol? All risk factors for pleural infection, but I think there's probably something more to it. We linked this HEADS data with Public Health England data on flu and found that flu spikes often were followed by a spike of empyema as well. But interestingly, chronic respiratory diseases such as COPD, ILD are not linked with empyema or pleural infection and are actually protective for it. So is that because patients are getting antibiotics earlier in those conditions or because they're getting steroids earlier? I don't know. What are the bugs that are causing pleural infection? Well, they're not really the bugs that cause pneumonia. This is a nice review by Hassan, a doctor from Oxford, who did a systematic review of all the papers that had looked at microbiological yield and found that Staph aureus is the most commonly grown. It was pneumococci in the tropics, most likely because of HIV. But in our sort of temperate region, it's most likely a strep viridans. So it's called strep viridans because it stains green on an agar plate. But it's not a typical bug for causing pneumonia. So it is again, a slight mystery of pleural infection as to why that is the predominant agent. Another thing he found was that the yield was not brilliant. Now, he quoted it as 52%. So the idea that you'd send frank pus off to the lab, and yet the yield was only come back as 50%, and it's nowhere near this in real life. It's more around about 20%. We just don't grow the bugs particularly well in the lab. And what can we do about this? Well, you can either send it off in back-tech bottles. Now, I don't know how many of physicians in the audience, but just sending it off in blood culture bottles really kicks your yield up. You can do a little bit more fancy. So Nick Kalidis has just published the TORPID study, which did 16 sRNA, and on the pilot study, which is a large observational study of pleural infection, and found that actually almost 80% of these cases, maybe 16S is a little bit too sensitive, but 80% of cases are polymicrobial. So you're finding more than one bug down there. If it was going to be monomicrobial, it was most likely to be a strep pneumoniae. So it's like a zoo down there, basically. And is that really useful as a clinical tool? Probably not, because it's not going to help you to narrow down your antibiotic choices, but it's very interesting from a scientific point of view. And then finally, another nice study from Oxford is the audio study, where at the same time as putting in a chest strain for pleural infection, they also did a biopsy, and they sent that biopsy off to the lab. So instead of just sending the fluid, the pus, they sent the biopsy sample as well. And they found that it's massively increased their yield. So you had blood cultures, which you're likely to get a hit in around about 10%. The pleural fluid around about 20–25%, which is what I think we see in clinical practice. And then if you send off the biopsy, it's more like 50%. I wouldn't do routine biopsies in patients with pleural infection. But actually, I think it's useful because it shows us actually these bugs are hanging out in the pleura, where there's good blood supply, where there's good oxygenation, not just freely floating in this sort of nasty, putty fluid. In terms of antibiotic choice, now in Bristol we've got an amazing pharmacokinetics lab, and as part of my PhD, what we did was we did serial sampling of patients with pleural infection. So when a chest drain was put in to drain the fluid, we took blood and pleural fluid samples and timed that with antibiotic administration, just to see. The fear from physicians was that these complicated parapneumonic effusions, the antibiotics probably wasn't getting in there. It wasn't really based on anything in particular, apart from a small study in white rabbits from New Zealand. So we wanted to say, is this really true? Is it right that the antibiotics aren't getting there? Because it made no real sense to us. So we looked at lots of antibiotics really, but the sort of headlines were that in the antibiotics we use commonly, there is no real difference between the pleural and the sort of blood penetration at all. In fact, the sort of the profile for pleural fluid is actually optimized. If you look at piperacillin, so piperacillin, tazobactam, tazocin, one of the antibiotics we hand out like Smarties in North Bristol, the profile, the dosing profile is actually much better in the solid line of pleural fluid compared to the profile in serum. The only thing we found was cotrimoxazole, which we often use to treat pneumonia. The trimethoprim does not get into the pleural fluid for whatever reason. And so we've taken that off our formulary for patients who come in with pneumonia with any sort of pleural effusion at all. How long should we give the antibiotics for? Now that's really as how long as a piece of string at the moment. The guidelines say 4 to 6 weeks, based on nothing really apart from it's just a nasty infection, so let's give it for longer. 2 studies have tried to answer the question, but unfortunately just a bit too small at the moment, with 50 patients in each, to answer a question that probably requires 1,000 or so, given the event rate for treatment failure is actually quite low. In terms of the diagnosis and definition, I suppose this is important. When does a simple parapneumonic effusion become a pleural infection or become an empyema? Well, an empyema, in its sort of historical sense, is basically pus from the pleural space. So it comes out and it's pussy, or it smells, or something like that. I've had one patient when I did the incision. It came out, it absolutely stank, and she said, "Gosh, is someone eating a Chinese?" It's like, well, you need to change your takeaway, because it did not smell anything like that at all. It can really stink, but that's a frank empyema. Or if you grow something, then that defines an empyema as well. However, as we know, we don't often grow something. It doesn't always look that bad, so we use pH as a good proxy for pleural infection. But you can see, this is how things and dogma gets ingrained into medical practice, is that there was Professor Light, our godfather, in 1980, did a retrospective analysis of just 26 patients. And he found that actually, pH less than 7.2, taken from the pleural fluid, they were likely to go on to need a chest drain. But even he said in his paper at the time, take that with a pinch of salt. However, then everybody started doing it. All the prospective studies are using the same cutoff. So by the time you meta-analyze it 15 years later, of course, the ROC curve is going to look brilliant. But that's because everyone's now using that cutoff. And it's impossible for us to drag our way from that cutoff now. And it's never been prospectively analysed. So what can we do? So there are other pleural fluid biomarkers out there that we have tried. In Bristol, we looked at SUPAR, soluble urokinase activating receptor. And in Oxford, Dr Badawi looked at PI1. Both of us really trying to move the field forward and say, can we try and move away from pleural fluid pH? Because the problem with pH is that it doesn't tell you whether a patient's going to go on to need a chest drain, surgery particularly well. It doesn't proxy very well for ultrasound findings. So pleural fluid SUPAR, we looked at it was a retrospective study of all the patients that we had in our freezers. We did SUPAR on them, and we found it was actually performed a lot better than a lot of our currently used biomarkers in terms of the requirement for surgery. and also for needing a chest drain as well. At the moment, just a research tool. And actually, Ehab Badawi, he probably went a step further, because what's really difficult is actually prognosticating these people at the front door. They get to pleural infection, you've got no idea how aggressively to treat them, you don't know what their mortality is. And Pi1 was actually able to tell the difference between patients' length of stay and also survival, independent of all other biomarkers and radiological findings that we have at the moment. These are our pleural infection guidelines that have just come out from the British Thoracic Society. I throw them up there just because they're just out there, more of a plug really. But again, we're still anchored to pH. There's a little bit of a shift away because we've now got this intermediate group, but we still use 7.2 as high risk for complex pneumonic effusion or pleural infection, insert a chest drain. I don't think everyone needs a chest drain. You'll often see young men come in, they're in their 20s and 30s, they've never been to hospital before, they get pleural infection, you put a chest drain in and they're in for weeks because there is a huge amount of clinician stasis once a chest drain goes in. No one really wants to take it out. Are we sure we're definitely going to take it out? The patient stops moving from the bedside because they've got this slightly sore drain in with a little bucket on the floor. It's a bit like a ball and chain really. They don't really want to move, and so that and they become really institutionalized. So we're currently just about to open a study in Bristol looking at a slightly more conservative method of draining the fluid. What we're going to do is we're going to randomize, and hopefully Cambridge will be taking part in this, we're going to randomize patients to receive the current standard of care, which is a chest drain, versus what's called a therapeutic aspiration or therapeutic thoracentesis, where we just take the fluid off in one go, take as much as we can, and then put a bandage over the top. And the hypothesis is that that will reduce hospital length of stay, which will be the first powered study of its type asking that question. So if you put in a chest drain or you've done a thoracentesis and that fails, well, what's the plan next? Well, we're pretty simplistic, I'm afraid, in pleural medicine. The first, what we've done is also we could stick in a bit of salty water. So my boss, Professor Maskell, he did this study where he just put lots of fluid in, so around about nearly a litre a day, 250, 3 times a day, drained into this chap who looks not particularly thrilled about it, and basically just washing out the pleural space. It's only been tested once, but it seemed to suggest that patients had a reduced need for surgery, but it was a single centre study where the clinician who was running the trial made the decision around surgery, so definitely some confounders there. We used to use streptokinase, so basically the idea of a clot buster that was put into the chest to try and break down some of that honeycombing that I talked about earlier. This is the largest trial that's ever taken place in pleural infection. 454 patients testing the standard care against placebo, and the standard of care was absolutely negative. It did nothing to reduce mortality or length of stay in these patients. A massive finding at the time. Feels slightly embarrassing coming to this incredible place where you're doing incredible science, and then this is what I'm presenting as the sort of cutting edge of pleural infection research. But this is a viscometer. So essentially you take a patient's pleural fluid and you test how quickly it drips through the needle, and a high-tech sort of stuff. But what they found was that if you took your clot buster and you added DNAs, it dripped through a lot faster. So the feeling being you can't just break down the septations, you also have to make the fluid a little bit less thick as well. And so, again, Nick and Naj did a study called MIST-2, where they tested DNAs versus the clotbuster in combination. So they tested placebo, clotbuster by itself, DNAs by itself, and then the two together. And you can see that the change in pleural fluid on the chest X-ray did significantly reduce, with some positive secondary outcomes as well. So that is now our new standard of care. When to do surgery? Well, around about 10 to 15% of these patients go on to need surgery, depending on the sort of centre you're in. If you go to a surgical centre, you're more likely to get surgery. Go to a barber, you get a haircut. But if you're going to do surgery, more conservative the better. And in Oxford, they've run the MIST-3 trial, which is a feasibility study, randomising patients to receive either standard of care, which will be a chest drain, early surgical opinion, or early intrapleural therapy that I've just talked about. that was even though running COVID, they did an incredible job. They randomized that number of patients. It seems to be a feasible study, and so they've just got the money to do it on a grand scale. It's going to be around about 600 patients, so a huge undertaking. And hopefully we'll have the answer to that in 5, 6, 7 years, who knows. And then finally, could we be a little bit more clever? The new guidelines for pneumonia from NICE have just come out, suggesting that in advanced pneumonia or severe pneumonia, we should be giving steroids. As I said at the start, my feeling is that pleural infection is a hugely inflammatory process. And there's massive upregulation of all these pro-inflammatory cytokines. So could we try steroids at some point in the treatment process? It's been done before in pediatrics, so just in 60 kids who had some sort of pleural effusion on their chest x-ray with pneumonia, and it reduced their time to recovery. It's also been done in adults. Gary Lee in Australia and Debbie Fitzgerald, they did this in 2022, but it was just a feasibility study. So they randomized 80 patients, 52 to dex, 28 to placebo, and it didn't have any effect, but they randomized all comers. So you could have had simple pneumonic effusion that was never tapped, or frank pleural infection. Didn't see any effect, but I don't think that question's answered, especially with a relatively small study like that. So I think there would be room for a study of steroids in pleural infection as well. And then finally, something maybe a little bit more crazy is, could we be a little bit more targeted? So we noticed, one of my colleagues, Fergus Hamilton, who's a geneticist, as well as being an ID doctor, we're trying to publish this together. So we looked at this prospective observational cohort of pleural infection we've got. We looked at IL-6 levels in all these patients, which are completely off the scale, by the way, compared to in serum. So like 20 to 1,000-fold higher than you'll see in serum levels. So it is probably being produced by the pleura. And it correlates with effusion size on chest x-ray, it correlates with length of stay, it correlates with mortality, the IL-6 levels in the pleural fluid itself. Then he's also done a 2-sample Mendelian randomization. You get about 1,600 cases if you add all the large cohorts together, because pleural infection remains relatively uncommon. And for pneumonia, blocking IL-6, okay, is harmful. But that's pneumonia, all comers, even in pneumonia just diagnosed by your GP. We know that tocilizumab that blocks IL-6 is useful in COVID, but then that's the result for pleural empyema. So on the face of it, very protective in pleural infection. But you would, before we had COVID, using tocilizumab in patients with active infection was probably seen as fairly crazy. Using it in somebody with deep-seated infection, I still think you'd have a few eyebrows raised. So there's some work to be done to try and move the field forward. And finally, how can we prognosticate our patients better? Naj and Nick came up with the RAPID score, which essentially is a bit like the CURB-65 score for pneumonia, where you look at patients' urea, their age, the purulence of the fluid, where they got their infection and their albumin. And you can actually really accurately prognosticate these patients depending on their RAPID score, which is actually really helpful when talking to the patient about their survival and talking to the surgeons as well about whether you take them for surgery or not. That's the new BTS guidance, which just covers basically what we've talked about. And finally, a little bit of a plug. This came out in Lancet Respiratory. It says, respiratory research remains vastly underfunded at the moment, and especially in infection. So what we've done is we've set up, with the help of Charlotte, we've set up a James Lind priority setting partnership. So if you do have time, that's all over our Twitter as well. You can scan that QR code. And while you're doing so, I'm going to tell you a QR code anecdote. So you've got plenty of time to scan it and give us your sort of priorities in research in pneumonia and pleural infection. But basically, I've now been tied into a contract with a QR code company, which I didn't even realize. So we have to get this survey done quickly. Otherwise, I'm going to keep having to pay £50 a month for the pleasure of this QR code. So let's get it done, okay, so I can like block them from my bank account. But thank you very much for listening. Thank you.
Thank you. Any questions for Dave? Luke?
Question. Does it matter what type of chest drain you put in when it comes to drainage?
Yeah. The official answer is no. You can put a small bore drain in, you can put a large bore drain in, and there's a huge difference when it comes to a patient seeing somebody approach you with one or the other. But that data is based on the MIST trial that I showed you, so the early streptokinase studies. And what they did is they basically just looked retrospectively at patients who had small drains and large drains, and they said there's no difference between the two. But to my mind, that's not a question that can be easily answered retrospectively, because if I was a clinician and I saw an incredibly complicated space, I would put in a large bore drain. So those patients, you're biasing the large bore drain arm by doing that. So it's never been answered prospectively. I still just stick in a small bore because actually the kind of limiting factor is often just the 3-way tap at the end, because that's really quite narrow, and that's the same on both.
And the ones that fail from a small bore, generally the surgeons will say, well, upsize them
Yeah, exactly.
first anyway, so the crossover, I guess, is
Crossovers are massive
huge.
as well, yeah.
Sid.
Yeah, very interesting. Is there a reasonable explanation why IL-6 is protected against pleural infection, but it is not? This is promoting pleural infection. No, it's protected.
I'd say, well,
This inhibition reduces the infection.
I mean, we still need to, so I mean, if the grant application arrives on your desk, don't boot it out. I mean, my theory is that, much like in COVID, it's all about timing. Okay, so you wouldn't want to give it early in COVID when actually you need your neutrophils to be functioning and fully. But actually, pleural infection, much like COVID, suffers from this sort of cytokine storm where there's massive recruitment of pro-inflammatory cytokines that are probably doing damage in the end. It all ties into, also it all makes sense because, you know, we never grow anything from this pleural fluid. We have very good antibiotic penetration, and yet these patients have fevers and CRP for weeks on end. And so I think it's the immune system, the perpetuation of this cytokine storm, that is driving a lot of this.
And I guess we know in pneumonia that the neutrophil migration happens in hours rather than days. It goes in and then it stops pretty early on, and usually before you're symptomatic for the pneumonia, whereas in pleural infection, that isn't the case.
Yeah.
There's ongoing inflammation.
Yeah.
And so is there anything done in humans on innate response activator B cells? So the pleural space is highly rich in a very specific type of B lymphocytes called innate response activator B cells. In fact, they have been shown, at least in mouse models, to be very important in protecting against microbial sepsis and pleural infections. They are very they are important in producing IgM antibodies, even natural IgM antibodies, so protecting against infections, etc. So, is there anything done in humans about this?
I mean, I think it's reasonable to say that in pleural infection, and maybe in pleural medicine in general, we've done the big trials before understanding a lot of the pathophysiology behind a lot of these conditions, and we struggle because there's no decent mouse models. A lot of the mouse models are turpentine-induced pleural effusions followed by inoculation of some sort of pasturella or something along those lines. So we've never, and I've never seen anything like that myself in the literature. So no is my answer. And what I think we really need to do is to understand the pathophysiology better of this condition, which is just going to take actually tricky serial sampling, which is very, very challenging in this condition. If you can come up with a mouse model, then that'd be great.
Well, it's good to know whether such papers published in Science and JEM in mice, whether there is some translation in humans.
Certainly in the when we have done immunophenotyping of pleural fluid samples, we don't see many B cells. Actually, that's the fluid rather than the pleural tissue itself. The pleural tissue may well have the B cells in it for immune surveillance, but it's neutrophils and the occasional bit of monocytes that you see in the pleural fluid, and a different type of neutrophil. That ICAM1 is different, as we've done kind of looking at oral neutrophils and pleural neutrophils and blood neutrophils at the same time. We've got a slightly different phenotype, but very few in the fluid, but we haven't done tissue biopsy for phenotyping them. Good. Any other questions for Dave? Stephen?
Why staph? worldwide, I honestly don't know. Much like I don't really know why strep viridans is the most common here, because a pneumococci would make the most sense, wouldn't it? But no, I don't know.
Stephen's a global health researcher who's interested in infection, so you may want to talk some more. Great. If there are no other questions, David, we will say thank you very much for your talk.
Thank you very much.
We hope we've generated some interesting. And our next speaker this afternoon is going to be Scott Ritchie, who's a Senior Research Associate working with Mike Inouye. He's going to speak to us about cardiovascular risk and predicting risk using multimodal data at a 10-year time horizon. So he's just having his quick microphone change, and then he will be with us to share how we can work out what's going to happen to us 10 years into the future from our data now, which for those of us who are getting slightly older is a source of increasingly pressing concern. I'm hoping if I fast forward, if I put this one forwards, we will switch over. Great.
Thank you.
Thank you, Scott.
Thank you. All right, great. Yeah, thank you for having me. As Charlotte was saying, that I'm a Senior Research Associate in the Department of Public Health and Primary Care, also a Fellow with the British Heart Foundation Centre for Research Excellence here at Cambridge. And today I'm going to be talking about enhancing cardiovascular risk prediction using polygenic risk scores and metabolic biomarkers. And click works, excellent. So risk scores for cardiovascular disease within 10 years have been around in some form in the clinic for almost 50 years now. And as a whole, they generally center around a common set of risk factors that include age, sex, whether a person smokes, has diabetes, what their lipid levels are, and what their blood pressure is. And over the years, there's been more and more scores that have been developed in different regions of the world. And today there's a few commonly used ones, and the one I'm going to be talking to you a lot about today is Score 2, which is recommended for use in Europe and is something that's the Department of Public Health and Primary Care has been instrumental in helping develop. So people like Stephen Kaptoge, who's in the audience, Lisa Pennells and Emanuele Angelo Antonio were involved in leading the development of Score 2 and also developing extensions for high-risk groups like people with diabetes and people with older elderly patient groups. And so what I've been working on for the last couple of years is looking at what the value of various new molecular assays is for helping improve risk prediction for cardiovascular disease within 10 years. And the main area that I've been interested in is primary prevention of CVD. So this is just showing you the European Society for Cardiology guidelines within Europe, which use Score 2. So Score 2 is somewhat unique in that it also uses the geographic region of Europe a person is having their risk evaluated in as a way of determining what absolute risk they're at. And the reason I'm interested in primary prevention rather than more specific patient groups is that if you take any person who's not diabetic, isn't particularly old, who has a CVD event, you'll find that a substantial fraction of these, depending on the risk score and risk threshold, between 40 and 86% of them, if you go back 10 years in the past, you'll see that they would have been evaluated as low risk with the recommended clinical risk score. So for a really long time now, clinical guidelines have recognized that there's a need to improve CVD risk prediction with additional risk factors. And one of the things that's been particularly promising recently is polygenic risk scores, which capture people's genetics beyond family history. But there's also been a long-standing interest in biomarkers as well for extending risk prediction. So we and others have shown in the past that polygenic risk scores can substantially add value and improve clinical risk prediction. And various cardiology bodies around the world have put out position statements in the last few years about how polygenic risk scores might be used in the clinic or how they can be integrated. partly due to this evidence and partly due to a large number of people coming in with genetic risk scores and saying, well, how does this relate to my cardiovascular risk? But the story with biomarkers has been a little bit less clear. So historically, there hasn't really been a whole lot of added value when people have looked at individual biomarkers of interest, so CRP being the sort of most notorious one people have looked at. But recently, there's been an emerging interest in aggregating lots of biomarkers together into biomarker scores. So with the emergence and development of sort of mature technologies for measuring lots of biomarkers at once from a single sample, people have started looking at this, showing that there are improvements in risk prediction. But people, when they evaluate risk prediction, they tend not to look at risk stratification. So, allocating people into low versus high risk groups, which is how you actually would use a risk score in the clinic. So this is what we set out to do using data from UK Biobank. So for anyone who's not familiar, in the last few years, UK Biobank has published data from sort of lipidomics and metabolic biomarkers from nuclear mass, I want to say mass spectrometry, is not, it's nuclear magnetic resonance is the platform. And these are enriched for biomarkers that are relevant to CVD, where there's been a huge amount of evidence gathered over the last few decades about the CVD associations of these biomarkers, which is partly why this technology has been measured in UK Biobank. So we developed these metabolic biomarker scores in UK Biobank. So we used a subset of the data where the biomarker data has been published already. So 170,000 participants who are eligible for screening for first onset CVD. And then we also have, through various collaborations, advanced access to the rest of the metabolomics data that will be, theoretically, it should have been published last year by UK Biobank, but I think they've been having trouble with the RAP. So it's expected to come out sometime this year, I think. So we built biomarker scores for males and females separately. So males and females have very different cardiovascular risk profiles, and many risk scores treat the risk factors differently. And we also developed them for coronary heart disease and stroke separately, because CVD as an endpoint is very heterogeneous. And what we found when working with polygenic risk scores is that actually training new models to predict the individual endpoints tends to work a lot better than trying to predict CVD as a whole. And so when we do this, we actually see across the whole distribution of risk. So look, this is looking at so the change in C-index over score 2 alone, that adding these metabolic biomarker scores improves risk prediction about as much as polygenic risk scores. We also here looked at a sort of amalgamation of various different clinical biochemistry biomarkers that are available in UK Biobank. These are sort of very well-established clinical biomarkers. They do a little bit better, but with the added complexity of, if you did want to use that in a clinical setting one day, you've got to essentially order multiple different assays, so it gets a little bit more complicated. And the information from biomarkers and polygenic risk scores is essentially orthogonal, so you can add them both together and get an even greater bump in your improvement in risk prediction. So that works out to be roughly a 10% improvement in the C-index over the whole distribution of risk. Reassuringly, when we go into the replication cohort, we see almost identical changes in C-index relative to score 2 alone. But of course, as I said earlier, we're not necessarily interested in the whole distribution of absolute risk. Being able to better predict whether someone's at 40 or 50% risk isn't that interesting when your risk threshold for treatment might be 10%. So we also looked at improvements in risk stratification. So following the ESC guidelines, using their risk thresholds, which are age dependent. Basically, if you're below 50 years and you have more than 7.5% risk, they recommend treating with statins. If you're over 50, your risk threshold is a little bit higher. And actually, when we start partitioning people into those low versus high risk buckets, we see that actually the information from biomarkers is about double that from what we see for polygenic risk scores, which is really encouraging. So, you know, polygenic risk is sort of capturing what's baked in from conception, and then biomarkers are capturing the more dynamic aspect of risk that reflects, you know, what's going on in a person's life, that, you know, is then going on to influence their disease risk. So again, reassuringly, we saw very similar numbers when we looked in the replication cohort. And then we wanted to ask the question of what might this look like if we were hypothetically to change screening practices to use these alternative models where SCORE2 has been extended. So as we all know, UK Biobank is not representative of the UK population. It's older and healthier. So you can see here the demographic distribution of age and sex for UK Biobank per 100,000 versus the mid-2023 population estimates from the Office for National Statistics. You can see that UK Biobank skews a bit older and a little bit more female. And actually, if you look at the CVD incidence rates in primary care patients who are CVD and statin-free, you can see that there's a, you know, as expected, there's this huge difference between UK Biobank and the CVD incidence rates you'd expect in the more general population. So we took these risk stratifications of cases and non-cases into, you know, different buckets of low, medium, high risk, and basically standardized their allocations to the demographics of the UK to get a more representative idea of what this might look like if we were to screen with these counterfactual risk scores that have been extended. What we see is what you might expect. So per 100,000 people, you'd expect there to be about 6,500 incident CVDs within 10 years. Using SCORE2 alone, you get 4,500 people identified as high risk, including 1,000 of those future CVD events. And then when you start adding polygenic risk scores and metabolomics biomarkers, you see more people are allocated to the high risk group. More of the CVDs that you expect to happen are allocated to that high risk group as well, and you get a corresponding reduction in number needed to screen. We also wanted to look at what this might do to treatment. So one of the things I forgot to mention on the previous slides with net reclassification is that we saw a little bit of an inappropriate reclassification of non-cases into higher risk groups. So one of the things with this type of modeling is that it's very easy to see improvements in number needed to screen or the number of people allocated to high risk. So actually in the best case scenario, if you want to optimize for number needed to screen, you just put everyone in the high risk group, give everyone a statin, don't screen at all, and then your number needed to screen is 0. But then of course you end up prescribing so many more statins than you actually need. So here what we looked at is how many statins are prescribed per event prevented. And reassuringly, even though there was a little bit of inappropriate net reclassification for non-cases, the number needed to treat didn't really change at all with using these more powerful models, which is really encouraging to see. We also looked at a more targeted approach. So just taking the people who would have been classified as medium risk by SCORE2 and following them up with rescreening with these extended models. And as you might expect, you get a little bit higher numbers of people allocated to high risk, number of cases caught in that high risk group, but a little bit of a bump in the number of statins prescribed per event prevented. So an overall summary of what we've seen is that biomarkers compared to polygenic risk scores are something that we should think about taking seriously in the future for enhancing clinical risk scores for CVD prediction. Over the whole distribution of risk, they improve prediction about as much as polygenic risk scores, but looking at clinically relevant thresholds, they almost double that risk prediction. You could look at either these sort of multi-biomarker panels like NMR, where you can measure hundreds of biomarkers at once, or you can consider the more conventional clinical assays, but at an increased complexity of, you're having to order multiple different assay types to get a little bit stronger prediction. And the potential impact on screening is, if this is developed appropriately in the future, is that it could increase the number of CVD cases that would be treated with statins by 7% or up to 12% with targeted rescreening. But of course, there are multiple challenges for validating clinical utility and the details of potential implementation in the future. So a lot of people have been involved in this work. We've got a very old now preprint out, which just has some of the discovery analyses in it. The replication analysis is all new as of a couple of weeks ago. So hopefully this will be coming out or back in review soon and out later this year. So yeah, thank you, and open the floor to questions. Thanks.
Yeah, I see your data is in your UK biobank, your marker, your method stratified better. Now you mentioned UK biobanker is the samples are older, so I just wonder if your markers more or less linked to the aging.
If the markers are linked to the aging. Yeah, you've got a good point there, and I have looked at some of the age breakdown a little bit, and actually as you get into the older UK Biobank participants, the biomarkers tend to do better at predicting future CVD events. So there may be some element of aging that is being captured by those that's reflected in these scores.
So yeah, I think
So maybe I missed it, but the improved discrimination is the same for females and males?
I don't think I have the results on these slides, but I have looked at that. I'm just trying to remember what the results were. So they were significant in both males and females, but I think stronger in males than in females is off the top of my head.
We miss a lot of women.
Yeah.
Correctly identified, right? So
Yeah, and I mean, part of that is just going to be is that the number of cases in women is so much lower than in men in UK Biobank, so we just have much less power there to do the score development.
And final question, the contribution of each component of the 11 clinical chemistry
Yes.
is equivalent, or is it skewed towards some
one
field that
marker
really
gives you
involved?
all of it, and the other 9 are useless.
Again.
All the markers of kidney function,
Yeah.
CRP,
Yeah.
and lipids and diabetes. I mean, these are classical what we expect. But my point is that how they are contributing.
Yes, some of them are definitely stronger than others. I can't tell you off the top of my head. I know cystatin C is certainly one of the stronger ones in there, even though
this is mostly kidney function.
which is mostly kidney function and inflammation. Even though we've purposely excluded people with CKD, and which there aren't very many of in UK Biobank, obviously. So, I think some of them are stronger than others, but I don't know the exact proportions off the top of my head.
And so your clinical chemistry and your NMR is a kind of summation of your genetics and your exposome. So I wondered, how much does this hold up across varied genetic backgrounds? The UK Biobank is more male, it's more middle class, they're more kind of healthy. They're also more white than the overall population. Do we know anything about alterations in ancestry and whether this holds true across ancestries or not? I was thinking about the data we had at last month's symposium showing that type 2 diabetes is a really different disease in people who were in, I think in that case, Malawi compared to Scotland.
Yeah. So I'm not sure about these metabolomics biomarkers specifically. I know here we haven't necessarily restricted to just like the genetically white UK Biobank participants. We've included everyone, but obviously UK Biobank is something like 85–90% white British, so not really capturing the information from the other ancestry distributions. I think there's a lot of issues with how we might generalize this. So not just ancestry, but also different risk regions of Europe, where we expect the distributions of the underlying biomarkers to be quite different potentially, is something, well, it's something we wanted to look at, but unfortunately, so one of the studies that came up in review was FinRisk, which has all of these metabolomics biomarkers measured, but unfortunately they've gone through a lot of funding cuts in the last couple of years, so it meant we weren't able to get access to the full FinRisk cohort to look at this. But yeah, I expect there to be differences. I don't know about ancestry. Certainly for polygenic risk scores, I would suspect it's going to be a much stronger influence of genetic ancestry than potentially the metabolomics biomarkers.
The metabolomics are partly determined by your genetics.
Yes,
So
yeah.
your genetics and your exposome, aren't they? They're kind of
Yeah.
sum of both. More questions, please.
Thanks, Scott. Very interesting. So I have two questions. So number one, probably this is already a bit too much towards the translation side, but what are, with the NMR especially, what are the economics currently? How much does that cost, or would that cost the patient at the moment?
I don't know the exact numbers. At least Nightingale, the company who's done the NMR profiling for UK Biobank, I think states somewhere publicly that the cost of their panel is equivalent to an assay for HDL and total cholesterol that you might order in the clinic. The NMR panel also includes those measurements as well.
Yeah.
So it should be reasonably cheap. I don't know how that compares to ordering, say, these 11 clinical chemistry biomarkers or the subset that are the strongest predictors. But yeah, certainly cheaper than doing something like proteomics.
Yeah, I mean, that's encouraging. And then I think point two, maybe I missed that, but can you, is my thinking about the problem, let's say you scale it up to, I don't know what population you're capable of, 65 million, 70 million, whatever it is. Can you try to put a number if that screening were introduced of cases prevented per year? What's my thinking? Am I missing
I'm sure
something?
there's a way of modeling that, but it's not something I've done. Yeah, but yeah, there would need to be cost-benefit analysis modeling of all of this.
That was sort of my first question, was also trying to push, but before we do the health economics, we need to do the biology.
Yeah, so I think before you get to the health economics, you need to look at the generalizability across different ancestries and risk profiles of different people would be the next step, I think.
I think there was a question behind you. Yeah.
Yes, I guess it's related in a way, but it's about implementation because right now when I look at those biomarkers, I can already see that it's not happening in the population. I mean, if you try to go and see your GP, even trying to get a blood test is difficult. So, and some of those specific biomarkers would not even make it into a blood test request from the GP. So you're saying if we were to do the screening, then let's say you want this score to be score to plus biomarkers, how can you implement that in current context?
Yeah, there would obviously be a lot of challenges around that. But yeah, I'm not qualified to sort of make speculative statements about that.
But I think you've got a kind of path to it, haven't you? You know that you need to work out the generalizability.
Yeah.
You then need to work out how much economically it would be a benefit, if it would be a benefit. Then you need to think about how on earth, if it is going to be a benefit and it is logistically possible to measure all of these things, how you would then get it done when we struggle to measure everyone who needs its blood pressure at the moment, let alone send a lab test off.
Yeah, so I think essentially the hypothetical scenario we've modeled here is that if you took all the infrastructure that's in place today and then swapped out your HDL and total cholesterol assays that you would measure as part of the routine screening if you can get to the GP, which I know is obviously a challenge at the moment. But if you would swap that out for the NMR panel, then you can get a bit of a boost in CVD prediction. Obviously, that's not a realistic scenario, but that's the way we've approached all these different comparisons.
Great. Any other questions for Scott? If not, we will say thank you very much, Scott.
Thank you.
And thank you very much again to Scott and David for two really good talks that make us think about the translation of the science to the bedside and improving care for patients. So thank you both. Thank you.